Dr. Naveen Ahmed. He is a respiratory consultant working in University Hospitals of North Midlands. He had been very effective educator and the faculty members in Farz Academy. And we have received very good feedback in his sessions as well. So over to Nagarda. So he will be discussing part 1 MRCP respiratory questions now.
Okay, thank you, Partho. Yeah, so everyone can see my screen, so I'll start off because this is the last session and I don't want to keep you guys waiting. So I'll try and be as quick as possible. So this will just be going through the questions, answers, and then trying to understand how to answer these questions. So the first question is of a 33-year-old gentleman. Now, everything that appears in the question is actually important. There are some things which you may have to ignore because, sometimes when we write questions, we have to give added information. Some questions will be where you just need to read the last line and then the answers, and your answer will be quite obvious. So reading through this question, you can see that this 33-year-old gentleman has had a road traffic accident and he's been admitted to hospital. When he's seen by the clinicians, he's found to be confused and has a mild temperature, and there is also some evidence of some petechial hemorrhages. So what is the most likely diagnosis? And the important bit about the question here again would be the timing of these symptoms. And you can see that accident 2 days ago. So that's also important. So thinking about that, you would think that one of these options would be possible. Now immediately you can see that option E is not possible. There is nothing in the question to suggest that the patient is had a chest pain or there is reduced air entry on one side of the chest. So pneumothorax can be excluded. There is no history of asthma, so you can immediately get rid of that. A chest infection is unlikely because he was in there is obvious case of him having had a car accident, and if you've had a car accident, there's an acute event, whereas a chest infection, you will see some chronicity to it where the patients would be unwell for a few days. So you're left with two answers really, and that is the fat embolism or pulmonary embolism. And both these scenarios are equally likely, but then what you have to consider is how old is the patient, what are the risk factors they have got, and what is the obvious information that is being given in this question. The obvious information is of a road traffic accident, the patient having been through surgery. Okay, so based on these facts, you can safely deduce that the correct answer should be fat embolism. Okay, now this is how the MRCP questions work, right? You will be immediately able to exclude two or three questions, and then you'll be left with two questions, and you'll have to find one which is the most appropriate answer. Okay, and these are, so I again said the most appropriate answer. So here the most appropriate answer would be fat embolism. Okay. Okay, so we move on to the next question. This is a 72-year-old gentleman who presents with weight loss and dyspnea and is diagnosed with a small cell lung cancer. So you can see that the part of the question where it tells you about the age, the symptoms, etc., they are not really important in this question. Okay, but they have to give that information because you have to get an because that is how the questions are structured. The important bit of information is the diagnosis of small cell lung cancer and what are the adverse prognostic features. So what this question is trying to understand is whether you are aware of what are the bad prognostic features of small cell lung cancer, and basically meaning that have you read about small cell lung cancer. So it is only directing you to make sure that you have read about small cell lung cancer. And this is a knowledge-based question. So if you know the answer, you know the answer. If you don't know the answer. Now we know hyponatremia can easily be excluded, again in the same way, because patients get hyponatremia with small cell lung cancer. Finger clubbing can be a part of all types of lung cancer, nothing specific for small cell lung cancer, same as hypertrophic pulmonary osteoarthropathy, which can be seen in all types of lung cancer. Cavitation on a chest x-ray can be seen only in squamous cell lung cancer. So immediately you've been able to rule out these four options, even if you did not have the correct knowledge. So the last answer is increased alkaline phosphatase, and that would be the correct answer to this question. So basically, it again tells you that lung cancer is an important part of the MRCP questions, and it is, you have to read through small cell lung cancer, squamous cell lung cancer, and sometimes they give questions on oat cell lung cancer as well, and its ramifications and the presentation. So read through them. Okay. So there are lots of other, bad prognostic features, which again, as I said, if you can read through the questions, etc., you will be able to know, what they are. So the right answer would be, as I said, alkaline phosphatase, which is greater than 1.5 times the upper limit of normal. A question on pleural effusion. So this is a young 20-year-old who's developed a generalized anasarca with, it's got fluid everywhere in his legs, in her legs, in her belly, as well as in her chest. And immediately you can think of all types of failures. Okay, so any condition which causes collection of fluid in your legs, in your belly, as well as in your chest would be related to one of the three types of failures. So you could have congestive cardiac failure, you could have chronic liver disease or hepatic failure, or you could have renal failure or chronic renal failure. Okay, so the investigations are given. So ALT is normal, bilirubin is normal, albumin is pretty low, and the cholesterol is high. So immediately you can see, looking through the options, so one of the things that you can probably rule out is, any hepatic cause, because ALT and bilirubin are normal. Nothing is given in the question setting to suggest any, sort of lung cause for this. But if you look at the answers then, so they're asking you whether A, serum protein electrophoresis. Now again, serum protein electrophoresis would be relevant if you were thinking about some sort of myelodysplastic syndrome like myeloma. Myeloma we know can cause renal failure, but not specifically renal failure which is in the nephrotic range, which is what this question seems to be suggesting. I mean, clearly, pregnancy can be ruled out. There's nothing here to suggest that, and pregnancy would not cause all these three problems. Anti-nuclear antibody is an autoimmune test for an autoimmune condition. So you may want to do it to rule out any form of vasculitis. Prothrombin time is not necessary because, as you can see, the liver function is normal. So the synthetic function of the liver is normal. The bilirubin is normal. If the bilirubin is normal, that indicates that the liver synthetic function is perfectly normal, and hence checking prothrombin time is not important. Okay, so you can rule that out. So you're left with E or C. And easily, as you can see, that the patient is hypoalbuminemic and hypercholesterolemic and presents with effusion, ankle edema and ascites, you immediately should start thinking about nephrotic syndrome. So what you need to do is a urine protein estimation. And if that produces more than 3 grams of protein, then you've clinched your diagnosis. Okay. So let's move on. Question number 4. So this is again a question on lung cancer with a small cell carcinoma of the lung. And you can see that, as I said, you must read through this. Which of the following non-metastatic manifestations is she most likely to develop? So basically what we're talking about is a term which is used in cancers, paraneoplastic syndrome. Okay. So which of these options correctly tells you of a paraneoplastic syndrome that can occur with a small cell carcinoma? Now you start with A, myasthenia gravis. Now we know myasthenia gravis is an autoimmune condition which is associated with acetylcholine receptor antibodies. So immediately you can throw them out of the window. Hypertrophic pulmonary arteriopathy, as I've suggested in the previous question, can be seen in all types of cancers, in lung cancers, and hence really not specific for small cell. Eaton-Lambert syndrome is a possibility. Erythema gyraatum repens is some sort of a cutaneous manifestation. Again, not really, very rarely seen in any kind of lung cancers. Ectopic PTH-related peptide secretion is more common in squamous cell lung cancer and not in small cell lung cancer. Okay, so easily in this question, you've ruled out 4 options. So what you're left with is Eaton-Lambert syndrome. And that is the correct answer. Okay, so again, you don't have to for the exam purposes, please try and focus on the right answer and how to get to that answer. You will have enough time to learn more about the disease as you go along during training as well. So you know a little bit of that, but specifically focus on how best to answer the question. Okay, I'm not going to test you if you know all the syndromes that can happen in medicine. That is not what this exam is testing you. It is testing your knowledge of certain specific things which are important and you should know when you're performing as a junior doctor in the hospitals. The fifth question is about a 63-year-old lady who's got rheumatoid arthritis, and she's been on some long-term therapy to control her disease. So she's now developed breathlessness and she's got some changes on her x-ray. Interstitial shadowing, the term interstitium indicates that the changes are relevant to the pulmonary the lining of the pulmonary lobule, which is in the interstitium, and a disease that affects the interstitium in the lungs is usually fibrosis. So what this question is asking you is, which drug used in rheumatoid arthritis can cause pulmonary fibrosis? Okay, and this is again something that you will have to read through. There are few drugs that can cause pulmonary fibrosis, and we know that methotrexate is one of them. Okay, so this is a straightforward answer. You will just go straight for methotrexate. You will just ignore everything else. So methotrexate is one. Then you get bleomycin. So these are the common ones: methotrexate, bleomycin, nitrofurantoin. Very rarely you will get somebody having pulmonary fibrosis with metformin. So this the theme of the question can be slightly different, where they will present you with an elderly lady who's been put on a drug to prevent her from having urinary tract infections. And that drug is usually nitrofurantoin. And then the question would be, she will present with breathlessness and her chest x-ray shows evidence of fibrosis. So what is the right answer to that question? Okay, so please read what are the drugs that can cause pulmonary fibrosis, and then you will be able to answer these questions straight away. So the answer in this question, as you can see, bleomycin, methotrexate, procarbazine, these are indicated. And we see that quite commonly in patients who are on methotrexate. A question on COPD and whether a patient can fly. So this is a question on whether this patient can fly with her COPD, and a question on hypoxic challenge test. So again, specifically, you will have to know the criteria for hypoxic challenge test. Okay. So she's got an FEV1 which is reasonably good at 40% predicted. Her stats on air are 92%, and the hypoxic challenge PO2 is 7.7. Hypoxic challenge involves giving patients 15% oxygen. Okay, so normally on air we are breathing 21% oxygen, but when you have a hypoxic challenge test, they give you 15% oxygen, because that is because as we fly in an aeroplane at heights of about 4,000 feet, air is thinner. Okay, the atmosphere is thinner, and hence the PO2 of oxygen at that height falls to 15%. That is why we do a hypoxic challenge on 15% oxygen. And there are criteria which the patient should fulfill with respect to how much the PO2 is for them to require oxygen. So in this question, the hypoxic challenge test result was a PO2 of 7.7, and the correct answer is that if the PO2 is more than 7.4, then this patient does not require any oxygen. But if it is between 6.6 to 7.4, then it should lead to another test. And if it is less than 6.6, you straight away give them in-flight oxygen at 2 liters per minute. Okay, so the PO2 here was 7.7, and the correct answer is A, which means that she does not need any oxygen, as her PO2 is pretty good. Question 7 is on vaccination, and which type of vaccination can this gentleman have? A 57-year-old who has been on reasonably recurrent courses of prednisolone. Anybody who's been on prednisolone at a dose of at least 5 to 10 milligram per day for more than 6 months would be considered to be immunosuppressed. Okay, and if this patient with asthma who wants to now take up a healthcare job in the NHS is needing that, then which of the vaccinations should be contraindicated in this man? Now, because obviously the patient is immunosuppressed, you would think that the patient should not be given any live attenuated vaccines. So the correct answer for this would be the BCG vaccine, which is a live attenuated vaccine. Okay, 76-year-old lady who presents to the clinic with 4-month history of tiredness, headaches, and breathlessness. Okay, and she's hypoxemic on air. Her chest X-ray is normal. So all this information is important. The symptoms, the duration of symptoms, chest X-ray findings, and what her VO2 is on air. And as you can see, that she's basically got type 2 respiratory failure with a raised PCO2, a low PO2, and a mildly acidotic pH. But interestingly, she's got a raised bicarb. So basically, something has happened for her to now develop decompensated type 2 respiratory failure. So this is what I would say as acute on chronic type 2 respiratory failure. If the bicarb was normal, then it would be acute type 2 respiratory failure. Okay, so basically, and because she's got a 4-month history, you can see that something has been brewing over the last 4 months. Something has been going on, and now she's probably had some sort of an infection or a decompensation event, and she's tipped into type 2 respiratory failure. So what is the most likely cause? So let's go through the options again. So PE, again, if this is a 4-month history, it cannot be PE. You cannot live with PE for 4 months. So that's immediately taken out. Neuromuscular weakness. So neuromuscular weakness, for example, if you've got motor neuron disease or muscular dystrophy, then that will affect your muscles of ventilation. And if it affects your muscles of ventilation, then you know that you can go into a type 2 respiratory failure, particularly when you're asleep at night. Option C, left ventricular failure, chest X-ray is normal, ruled out. Lobar pneumonia, chest X-ray is normal, ruled out. Bronchial asthma, asthmatic patients do not, unless they are having an acute attack, they would not be hypoxic. And because there is chronicity to the symptoms, asthma is ruled out as well. So the only option you're left with is B, neuromuscular weakness. So basically this lady has got some form of neuromuscular weakness causing ventilator failure, leading to acute on chronic type 2 respiratory failure. So option B is the correct answer. Then you've come to 52-year-old gentleman who's had TB, and this has been diagnosed for the last 3 months. He, as sometimes very commonly happens with some of our TB patients, they're lost to follow up, and then they will reappear with a very severe disease, hemoptysis, fatigue, and a high temperature. So once again, his sputum cultures are tested and they are AFB positive. He's suspected to have MDR-TB. Now, as you can see, 1, 2, 3 lines of information in this question actually do not mean anything. Okay, they are there just to paint a picture. What you are being asked now is what would be the strongest risk. So what you're being asked is all about MDR-TB. So you've read through all that. That has taken your time, but actually the meat of the question lies here, which is, do you know about MDR-TB and what are the risk factors for MDR-TB in the UK? Okay, and again, so we have got 5 options here, and if you know about the risk factors, you will know which will be the correct option. So the option D is the correct one over here, which is HIV. So these are the risk factors for MDR-TB. Obviously, somebody who's had a prior TB but has been not adherent or compliant with the treatment, if they are a contact with a known case of drug-resistant TB, if you're born in a foreign country, particularly with a high incidence. So I think the incidence of XDR-TB and multi-drug-resistant TB is quite low in UK. There are pockets of high incidence in London, in Manchester areas, and in some parts of Birmingham, but it's not too bad. So as you can see, if you're a resident in London, that is a risk factor for MDR-TB. Male gender is a risk factor as well, and you have to be between that age group of 25 and 44 years. So this is a 37-year-old who presents with 2 months of chronic cough with purulent sputum and shortness of breath on exertion. So again, important information in the first line of the question. Okay, 37, 2 months, cough, sputum, breathlessness. And there are 2, and then next line, they are having infections almost twice every year, needing antibiotics. Again, another bit of information, important information, that his wife and him have not been able to have any children. He's a smoker, and you examine him and you find some crackles and wheeze with a chest X-ray showing some infiltration. You do some investigations in the form of spirometry with an FEV1 and FVC very close to each other. pH 7.4, PCO2 44, and PO2 of 84. Now, I'm sorry that this has not been changed on this slide. This should be in kilopascals because that is what is used in UK. So I would ask the organizers to please make sure that these are changed on for the next time. Please can somebody take a note of this, that the slide number 10 on this set needs to be changed with regards to the SI units. So what is the most likely diagnosis? So here you've got a 37-year-old man who's unable to have children, who's having recurrent chest infections, who's got some infiltration in the lung bases. This bit of information is rarely important, which is given in terms of investigations. The most information comes from the history itself, and you should be able to diagnose this condition. Okay, so what do you think is the right answer? Okay, so this is immotile cilia. Sorry? So this is actually A, which is an immotile cilia syndrome or primary ciliary dyskinesia, and that includes cartogeners if you have what we call dextrocardia as well, and this is an inherited condition. And the key things are male infertility, congenital heart defects, deafness, and hydrocephalus. So why isn't it asthma or cystic? Well, why isn't it cystic fibrosis? Because you have got to look at the age of the patient as well. Okay, I'm not saying that you cannot diagnose cystic fibrosis at that age, but really the key thing would be the immotile cilia syndrome here. Okay, this is not asthma because there is nothing there to suggest that. Alpha-1 antitrypsin deficiency is unlikely as the patient does not have any evidence of COPD on imaging and his spirometry is okay. Hypogammaglobulinemia is still an option, but again, in the investigations, we are not given the gamma globulin levels. So the most obvious answer would be the immotile cilia syndrome. And that's it. Thank you very much. So I think I finished on time. I will let the organizers take over here.
For sticking to time. You are the only faculty to be getting the time to do all this. Thanks a lot for that. Thanks for joining us. Thanks for your time, Narendra.
Thank you. Bye-bye. All the best, everybody.